Hello, everyone. I'm Maria Fleseriu. I'm a professor of medicine and neurological surgery and director of the Pituitary Center at Oregon Health and Science University in Portland, Oregon. It's a pleasure to talk to Chuck Rare about biochemical response, symptom control, and safety of oral octreotide capsules treatment in acromegaly, a post-hoc analysis of a large pooled database from 3 phase 3 clinical trials. Thank you for the invitation to discuss the data on behalf of my co-authors. When we're talking about acromegaly, these patients are diagnosed very late. The large majority of patients have macroadenomas. These are tumors that are more than 1 centimeter, and they will require, after surgery, medical treatment in sometimes more than half of the patients, and this treatment is lifelong. What we have now approved are injectable somatostatin receptor ligand. Sometimes we're using cabergoline off-label also as an oral medication for few patients that have mild disease. The oral octreotide has been recently approved, and I will discuss now the pooled data from all the studies that have been run for the last several years. And also for the patients with more severe disease, we have approved a drug, growth hormone receptor antagonist, that it's blocking the growth hormone receptor, so with a different mechanism. But the studies that we're going to present today would be with oral octreotide. The design was different between, this is pooled data, the design was different between the studies. However, all of them included patients that have been on injectable somatostatin receptor ligands, either octreotide or lenalidomide at the beginning of the study. So these were switch studies at the beginning for all patients. And what's interesting is that the patients received 6 months or more of oral octreotide, and the large majority of patients started therapy at the next time of the next scheduled injection. And this is important because we know now, based on recent studies, that the IGF-1s goes up and down throughout the months, and also that patients have symptoms towards the end of the injections right now. The dose titration was performed similarly across all studies based on both biochemistry and symptom measures. The biochemical criteria for enrollment and how the patients were assessed for outcomes was the same for each individual studies, but what was considered controlled was a little bit different, because for some studies, the IGF-1 was considered to be up to 1.3 normal, keeping in mind that the variation is 20% for normal, and in some studies, the normal was considered everything that was less than 1. So normal. And then symptoms were collected just in 2 of the 3 studies. That's a problem with pooled analysis. And in the third, the optimal study, the symptoms were recorded just as an adverse event of special interest. And when we're looking at the biochemical control of all these studies, the majority of patients maintain the control. And when we specifically looked everything to be less than 1, for IGF-1, remember, some of them consider control 1.3, 72% achieved that target. And then if we look at also the allowable, some of the studies to 1.3, then another 40% had control, because at that time, what control was 1.3 for that particularly study. What we found, and we didn't expect, that's why we have to do research, because sometimes the results are not the same as we thought. The biochemical response with oral octreotide was not associated with a category of prior injectable dose. We thought that if they were on much higher dose before, maybe they wouldn't be controlled with oral octreotide, but did not make any difference when we looked by doses, if they were on low dose injectable versus high dose injectable. When we had all the data, we also saw that over time, there was little change in IGF-1 level throughout the study from baseline. And when we look, including to the patients that were not responders also, they were overall stable. How about symptoms? And we have shown before in other studies that patients that have been controlled both on injectable and then switched to oral, they had oral octreotide, they had improvement in symptoms. When we pull the data, what we found is that patients responding to oral octreotide saw numerical improvement in symptoms of moderate or severe grade over the first 6 months. And also it's important to look that the study was open label in nature, but significant symptoms of joint pain and swellings have been noted as improvement. And for patients with long-term acromegaly, these are very important symptoms. From safety, the data for the pooled data looked very similar to the initial data. We know that with oral octreotide, the gastrointestinal symptoms are the most frequent one. So we looked at both timing and duration of certain events. And what we found was that the AEs, the GI, typically occur in the first few weeks of therapy with a median duration of 14 days. And discontinuation due to AEs that they're frequent overall was less than 7%. So overall, very reassuring. So tolerability seems similar to injection and confirmed most of the data in the individual studies overall. So this was what we had presented for the pooled data for oral octreotide. And as I mentioned, there are several new therapies that have been presented at ENDO and two of them are phase 3 clinical trials. So at some point, we hope that the patients will benefit of them if they will be approved. Pituitary had several studies presented, both for patients that have been on injectable, similar to what I have presented now before, and then switched to paltusotine. And then another study that patients have been off medication for a while or naive to therapy. And the data was also very reassuring that the patient achieved either continuing to be controlled, or for patients that were on therapy before or even naive, large majority of patients were controlled with, again, the oral therapy. Paltusotine is once a day, oral octreotide is twice a day, but clearly showing that the patients prefer that and improved symptoms. Another new exciting therapy is the injectable octreotide subcutaneously that also had several studies presented at ENDO. And that was, again, interesting because the patients will have control that's self-administered. And the study showed that the biochemical control was a little bit better in some of the switch patients than before with what we have right now approved. And furthermore, that symptoms were better controlled, and the patients clearly preferred to have an injections done by themselves rather than going to a clinic every month to have the injections. There were other data for new type of therapies of growth hormone receptor blockers in more incipient phases, but it's very reassuring to know that we have a bright future for the patients with acromegaly, and more studies are done, and hopefully some of these drugs, if not all, will be approved. So we have a better armamentarium to treat this severe disease for our patients.